Hello, my name is Dr. Keith Runyon, and the title of this talk is Management of Type 1 Diabetes with a Low Carbohydrate Lifestyle. I'm a medical doctor with specialties in nephrology, internal medicine, and obesity medicine. So what is type 1 diabetes? 1.25 million children and adults in the United States have type 1 diabetes, which accounts for 5 to 10% of all cases of diagnosed diabetes. Type 1 diabetes is an autoimmune disease in which the immune system destroys the insulin-secreting beta cells in the pancreas. Destruction of the beta cells results in the loss of both insulin and amylin secretion and the loss of regulation of both glucagon secretion by the alpha cells and liver glucose production. There is a genetic susceptibility to developing type 1 diabetes, but the fourfold increase in the incidence of type 1 diabetes over the past 50 years suggests that environmental agents must initiate the autoimmune process. Suggested candidates include viral infections, A1 beta casein in cow's milk, and gluten in wheat, rye, and barley. These agents may cause leaky gut, allowing intact foreign proteins to enter the bloodstream that trigger the immune system to destroy the pancreatic beta cells. I was diagnosed with latent autoimmune diabetes in adults in 1998 at the age of 38. LADA is a variant of type 1 diabetes in which the destruction of pancreatic beta cells occurs at a slower rate compared to juvenile type 1 diabetes and is often accompanied by insulin resistance. My beta cell destruction likely began several years prior to the onset of any symptoms. The first sign of my diabetes was unintentional weight loss. Unfortunately, I ignored this sign for the next 2 years. Next, I developed diarrhea, only occasionally at first, but as the months passed, it became more frequent. Then I gradually developed the typical symptoms of type 1 diabetes, including fatigue, increased hunger, thirst, and urination. I eventually saw a doctor in September of 1998, and my blood glucose was 398 milligrams per deciliter. I also tested positive for antibodies to gluten, but my small bowel biopsy did not show celiac disease. I abstained from all gluten-containing foods for 3 months with no improvement in the diarrhea. The diarrhea was actually a long-term complication of diabetes called diabetic diarrhea, which is caused by autonomic neuropathy of the intestines. So what are the rationales for a low carbohydrate diet for type 1 diabetes? Recent data from the type 1 exchange of almost 23,000 individuals with type 1 diabetes in the United States demonstrated that only about 20% are achieving their hemoglobin A1C targets. For children and adults, that's less than 7%, and it's less than 6% during pregnancy, with an emphasis on personalization of these targets depending on a number of factors. However, these targets do not represent normal blood sugars, which exposes those with type 1 diabetes to long-term complications. Thus, any safe intervention that improves glycemic control should be welcomed. The most important risk factor for long-term complications of type 1 diabetes is glycemic control. The closer to normal your mean blood glucose and coefficient of variation can be managed, the lower the risk of long-term complications, which include neuropathy, retinopathy, nephropathy, cardiovascular disease, cancer, and dementia. These latter two complications are not typically talked about as complications of diabetes, but they are certainly occur with increased incidence in those with diabetes. Coefficient of variation is a measure of glycemic variation, which is simply the standard deviation of blood glucose measurements divided by the mean blood glucose. Number 3, type 1 diabetes is a state of carbohydrate intolerance. Dietary carbohydrate accounts for most of the increase in postprandial blood glucose and stimulates the most insulin secretion in healthy volunteers. Dietary protein and fat have less of an impact on blood glucose and insulin secretion. Thus, a diet low in carbohydrate, moderate in protein, and the remainder in fat minimizes postprandial blood glucose, glycemic variability, and exogenous insulin requirements. Number 4, dietary carbohydrates are not essential in the human diet since hepatic gluconeogenesis produces all the glucose needed for metabolism. In fact, excess hepatic glucose production is ever present in those with type 1 diabetes treated with exogenous insulin due to the reduced amount of insulin reaching the alpha cells due to increased glucagon secretion and to the liver. Thus, a low carbohydrate diet reduces postprandial glycemic excursions and glycemic variability that in turn reduces the frequency of hypoglycemia and allows for near normal glycemia. Insulin requirements in persons with type 1 diabetes who consume a low carbohydrate diet are significantly reduced, depending on the degree of carbohydrate reduction. Thus, persons with type 1 diabetes can benefit from any degree of dietary carbohydrate reduction that they can sustain, even to a level of less than 50 grams per day, that typically results in nutritional ketosis with blood ketone levels in the range of 0.5 to 3 millimoles per liter. And finally, nutritional ketosis does not lower blood pH or increase the likelihood of diabetic ketoacidosis. Remember that diabetic ketoacidosis in type 1 diabetes is due to an absolute and/or relative insulin deficiency, not due to dietary carbohydrate reduction. I wanted to show you this study that demonstrates the rationale for a low carbohydrate diet for type 1 diabetes. The purpose of their study was actually to look at the effect of different macronutrient drinks on the secretion of ghrelin and its effect on appetite. But they also took measurements that I will show you that helps demonstrate why a low carbohydrate diet is helpful for type 1 diabetes. So they took 16 healthy volunteers and on different days gave them 3 different isocaloric drinks. One drink was 80% carbohydrate, the other was 80% protein, and the third was 80% fat. these are some of the measurements taken after, immediately before and after the ingestion of each drink. So you see in the dark circles the large increase in plasma glucose after the carbohydrate drink compared to the relatively no change in plasma glucose with the lipid drink in dark triangles and the protein drink with open squares. This graph shows the plasma insulin concentrations after the ingestion of the 3 drinks on different days, with the carbohydrate drink resulting in the largest increase in plasma insulin. The protein drink was moderately elevated, and the fat drink was the least stimulating of plasma insulin. So this fact means that a person with type 1 diabetes, when ingesting carbohydrates, would need to inject more insulin to address this elevation in blood glucose that occurred, but need much less insulin to cover a protein and fat diet, which is exactly what a low carbohydrate diet is. This is a page or part of a page taken from a textbook by Sir William Osler, one of the founders of Johns Hopkins University Medical School. In his book, The Principles and Practice of Medicine, this is from the 9th edition in 1921. And what he's showing is Elliot P. Joslin's prescription for a diet for a person with severe diabetes. You may be aware that there's a clinic at Harvard in Boston that is named for Dr. Joslin. So it's the Joslin Diabetes Clinic. So this was very soon published before the discovery of insulin. And you can see that the recommendation was only 10 grams of carbohydrate per day, 75 grams of protein, and 150 grams of fat as the prescription diet for these patients with diabetes. So the point here is that a low carbohydrate diet is not a new, radical, strange diet for type 1 diabetes, and it was actually the original diet used for type 1 diabetes for the reasons that we've outlined already. I wanted to show you this publication from 2018 that is it's not a randomized trial, but it's a survey of 316 people who with type 1 diabetes who responded to an online survey. And these people were members of Type 1 Grit, which is a Facebook group of people who follow a very low carbohydrate diet. And what they did is collect data on them and also confirmed as best they could the actual results of the data from the patient's doctor. So it was partially information from the patient and then confirmed with the patient's physician. I'll disclose that I was one of the 316 respondents to this publication. The mean time of the subjects following the diet was 2.2 years, and the mean daily carbohydrate intake was 36 grams per day. The next slide shows the results obtained by these type 1 diabetic persons as far as their results. So the hemoglobin A1C, the mean for the whole group, was 5.67%, which is very close to normal. The average continuous glucose monitor mean was 104 milligrams per deciliter. The standard deviation was 28 milligrams per deciliter, which is very low for persons with type 1 diabetes. The daily insulin dose was 0.4 units per kilogram per day, which is also roughly half of the normal dose that persons with type 1 diabetes need to take. And also you can note that all of the adverse events that are associated with type 1 diabetes were very low in these persons following a very low carbohydrate diet, including low rates of diabetic ketoacidosis, low rates of hypoglycemia, and also low rates of symptomatic hypoglycemia episodes while at home. So my personal experience with a low carbohydrate diet is as follows. After my diagnosis of type 1 diabetes in 1998, I immediately started on insulin. For the next 14 years, I continued my usual low-fat, high-carbohydrate diet that I grew up consuming, along with injections of Lispro and Glargine at a dose of 57 international units per day on average, while maintaining a hemoglobin A1C between 6.5 and 7%, as recommended. However, my quality of life was impaired by frequent symptomatic hypoglycemic episodes. It took, again, 14 years before I discovered this low carbohydrate approach to type 1 diabetes. And on February 8th of 2012, I started a ketogenic lifestyle with less than 50 grams per day of dietary carbohydrate. Since then, I have required about 25 international units per day of insulin while maintaining a mean blood glucose of about 100 milligrams per deciliter and a standard deviation between 18 and 25 milligrams per deciliter, which is actually a normal glycemic variation even in persons without diabetes. So I essentially have normal glycemia. I've had 1 or 2 symptomatic hypoglycemic episodes per year, which is remarkably fewer than I used to experience. I do resistance and aerobic exercise regularly. I don't smoke or drink alcohol. I've never experienced diabetic ketoacidosis. I've never had severe hypoglycemia, which means hypoglycemia requiring assistance from another person. Nor have I been hospitalized for any diabetes-related problem. I have not developed any new long-term complications of diabetes, and my autonomic and peripheral neuropathy that I developed at the time of diagnosis have nearly completely reversed. So currently, I measure my blood glucose before meals and at bedtime 4 times daily and more often if needed. I inject bolus insulin, which is Lispro, before meals and at bedtime if needed, 4 times daily. But I don't inject insulin between these times, even if my blood glucose is above my target of 70 to 130 milligrams per deciliter, so as to avoid insulin stacking and hypoglycemia. I inject basal insulin, which is glargine, once daily at bedtime. I use a simple mathematical formula to calculate my insulin doses that are described in Chapter 5 of my book, Master Type 1 Diabetes. In addition to glargine and Lispro insulin, I take metformin 500 milligrams before breakfast and lunch and 1,000 milligrams before dinner to inhibit liver glucose production and to reduce my total daily insulin dosage. And I'll talk more about this in a minute. My ketogenic lifestyle is enjoyable and easy to sustain, so much so that I have never had the desire to deviate from it. Persons with type 1 diabetes need to know an important consequence of having to inject insulin exogenously under the skin as opposed to the effects of normal beta cell insulin secretion. When insulin is injected, the concentration of insulin reaching the pancreatic alpha cells is 1/100th the concentration normally produced by the neighboring beta cells. This increases the concentration of glucagon reaching the liver by 3-fold. Glucagon stimulates liver glucose production. In addition, the concentration of exogenously injected insulin reaching the liver is 1/3 the concentration normally produced by the beta cells. Insulin inhibits liver glucose production. The net result is a significant chronic elevation of liver glucose production that must be compensated for with increased exogenous insulin. This in turn can promote body fat deposition because insulin is a signal to fat cells to deposit fat and to not release fat from the fat cells. A low carbohydrate lifestyle reduces the glucose entering the bloodstream and thus less exogenous insulin is needed. This also facilitates excess body fat loss and reverses insulin resistance and double diabetes. Double diabetes is a term used to describe a person with type 1 diabetes who also has insulin resistance and the features that are often seen in persons with type 2 diabetes. In addition to a low carbohydrate lifestyle, 2 medications can mitigate the chronically elevated liver glucose production: metformin and pramlintide, which is a synthetic form of amylin. Metformin directly inhibits glycerol 3-phosphate dehydrogenase, the key enzyme regulating gluconeogenesis. Gluconeogenesis is the process by which the liver makes new glucose molecules from lactate, glucogenic amino acids, mainly alanine and glutamine, and glycerol, which is the backbone of triglycerides, which are fat molecules. Pramlintide is an injectable pharmaceutical form of amylin, the hormone produced by the pancreatic beta cells, which is no longer produced in those with type 1 diabetes. Like amylin, pramlintide inhibits glucagon secretion by the alpha cells, slows stomach emptying, and suppresses appetite. Thus, metformin and pramlintide can reduce liver glucose production, improve glycemic control, reduce insulin requirements, promote body fat loss, and improve insulin resistance and double diabetes. Of note, pramlintide, but not metformin, has the potential to provoke hypoglycemia, but insulin dose reductions can prevent this effect. I wanted to talk about exercise and the benefits as well as how to deal with the effects of the effects of exercise on blood glucose in those with type 1 diabetes. This figure illustrates several relevant issues. For instance, the type of exercise, the intensity of exercise, duration of exercise, and the timing of exercise in relation to the last dose of insulin and one's training status all influence the blood glucose response to exercise. Environment like heat, cold, humidity, and altitude also can affect the absorption of insulin from the injected insulin site. In addition, changes in one's insulin regimen, the starting blood glucose at the beginning of exercise, as well as recent food intake, can all have an effect on blood glucose during exercise. And at the bottom, you can see a phenomenon which can occur in persons with type 1 diabetes called hypoglycemia-associated autonomic failure. And this is a condition created by frequent hypoglycemic episodes, as well as prior episodes of exercise, which increases one's insulin sensitivity, which can make one more susceptible to having hypoglycemia during exercise. And then bodily concerns, for instance, in women, their menstrual cycle can affect their insulin sensitivity and therefore affect blood glucose with exercise, as well as their hydration, nutritional status, as well as their levels of stress. This is just a large survey of about 18,000 patients on the impact of physical activity on glycemic control and the prevalence of cardiovascular risk factors in persons with type 1 diabetes. This was out of Germany and Austria, where persons self-reported the frequency of their physical activity. You can see the three columns, and I've labeled them for you as they categorize them as physically inactive, exercise taken 1 to 2 days a week, and exercise taken more than twice a week. And you can see the hemoglobin A1C improves as the activity is increased. The incidence of overweight and obesity decreases as physical activity increases. And several cardiovascular risk markers like HDL, triglycerides, and complications of diabetes like retinopathy and microalbuminuria all are improved with physical activity. Interestingly, also, the incidence of hypoglycemia and ketoacidosis are reduced with increased physical activity. So you can see that there are multiple benefits to doing more exercise compared to less. This is a study that is not strictly related to type 1 diabetes, but emphasizes that resistance exercise, like lifting weights, reverses aging in human skeletal muscle. And one of the ideas is that resistance exercise improves mitochondrial dysfunction, which is often seen in persons with diabetes, both type 1 and type 2. The mitochondria are the powerhouse of the cell that produce the energy needed for cellular functions, more specifically adenosine triphosphate, abbreviated ATP. So this is just a review article that emphasizes the importance of resistance exercise as for health as well as to reverse aging. I wanted to show you this study. This pertains to exercise not in persons with type 1 diabetes, but otherwise 10 highly trained, competitive, middle-aged athletes without diabetes. And what they did is they performed numerous exercise tests on these 10 individuals after they had adopted to a specific high carbohydrate diet with a washout period in between, and then a very low carbohydrate diet to see if the low carbohydrate diet had a negative impact on their athletic performance, which is often touted as a potential reason not to follow a low carbohydrate diet. So, as I said, 10 highly trained, competitive, middle-aged athletes underwent 2 31-day isocaloric diet periods, either low-fat or high carbohydrate, or low carbohydrate and high fat. This was a crossover design, so that means each athlete did both diets for the 31-day period with a 2-week washout period in between the dietary interventions. The primary outcomes they measured were athletic performance, substrate oxidation during exercise, continuous glucose, and cardiometabolic biomarkers were also measured. So this slide shows the carbohydrate intake of the low-carb diet, which was 40.9 grams per day, compared to the high carbohydrate diet of 384.7 grams per day. The protein intake was 141 grams per day on the low carb diet and 110.6 grams per day on the high carbohydrate diet. This is the measurement of the fasting beta-hydroxybutyrate levels of the athletes. Beta-hydroxybutyrate is one of the 3 ketone bodies that the body normally makes on a low carbohydrate diet. And these results are all in when the athletes were on the low carbohydrate diet. So now the gray part at the bottom of each graph indicates a beta-hydroxybutyrate concentration of 0.5 millimolar, which is considered to be kind of the minimum ketone concentration in the blood that constitutes nutritional ketosis. And it's a way to monitor compliance with the diet. So if a person is consistently below 0.5 millimolar, then they're probably not following the diet. So you can see that by day 28, which was, of course, prior to the testing athletic performance and other measures, all 10 athletes had achieved a level of 0.5 or more beta hydroxybutyrate. This shows one of the performance tests in terms of the time taken for each 800-meter sprint. These were conducted on a treadmill while they were taking numerous measurements. For instance, they were measuring their oxygen and carbon dioxide levels in their breath and numerous other factors while they were running on a treadmill. But this is their performance time in seconds for the 800 meters, and they did 6 of these one after another. So you can see the pre-diet and the post-diet performance times. In red is for the low carbohydrate diet, and the gray is the high carbohydrate diet. And as you can see, there's essentially no difference between their performances on either diet, and their performance did not deteriorate with repeated 800-meter sprints. So this is very important because it kind of dispels the myth that a low carbohydrate diet will impair one's sport performance. And it's also important to remember that these individuals were on the diet for 31 days, and that gave them time to adapt to the low carbohydrate diet. Many of the studies that have shown deterioration in performance on a low carbohydrate diet were done after 1 or 2 weeks being on the diet, which does not allow the body time to adjust to utilizing fat as its primary fuel, and was probably the reason for the lower sports performance. This shows they actually using those measurements of oxygen and carbon dioxide that I mentioned previously. They were able to calculate the rate of carbohydrate oxidation, meaning the rate at which they were burning glucose during the exercise for the 6 different 800-meter sprints. You can see at the top the carbohydrate oxidation rate before the diet compared to after the diet. And of course, they're separated by the diet, which is gray is the high carbohydrate diet and red is the low carbohydrate diet. And you can see that the athletes, when they were on the low carbohydrate diet, were utilizing much less carbohydrate in terms of grams per minute oxidized. And then at the bottom, you can see the measurement of their fat oxidation. So you have pre-diet on the left and post-diet on the right. And you can see that their fat oxidation rate increased significantly on the low carbohydrate diet. Now, in this graph, they're just showing you the measurement of blood ketones on the top left and the measurement of blood glucose on the bottom left. And on the right is measurement of blood lactate levels. You can see with the low carbohydrate diet, post-diet, that their ketone levels increased, um, whereas they were essentially unchanged on the high carbohydrate diet, which is what one would expect. At the bottom, though, a bit more interesting is that the glucose after the diet decreased. And that is consistent with the fact that they're not uh, having to utilize glucose. They're not ingesting as much glucose on a daily basis. And this is important because you can see that pre-diet, the blood glucose increased significantly in some of the participants. I'll skip the part about lactate, but I just showed it for those who were interested. Now this graph shows the ketones measured with each set of the 6x800 meter sprints. Ketones on the top, glucose in the middle, and lactate at the bottom. And again, you can see that post-diet, the ketones were elevated during all 6 sprints, and the glucose was lower in the individuals on the low-carb diet. And this graph shows changes in multiple factors. On the top left, we have insulin. You can see that their insulin levels dropped with the low carbohydrate diet, which again would be expected. The next top second graph shows high sensitivity CRP, which is C-reactive protein. That's a marker of inflammation, and that was reduced in the patients on the low carbohydrate diet and relatively higher on the high carbohydrate diet. The hemoglobin A1C also went down slightly on the low carb diet. Triglycerides went down on both diets. Total cholesterol and HDL were elevated on the high carbohydrate diet. On the low carbohydrate diet. The LDL increased significantly on the low carbohydrate diet. This is often but not always seen, and the VLDL, which is very low density lipoprotein concentration, decreased on both diets. This is a busy graph, but just focus on the top left graph, which shows the continuous glucose monitoring results pre-diet and post-diet. You can see the gray at the top and the red on the bottom. The red on the bottom is the low carbohydrate diet. And this shows each day for 28 days on the diet with a significantly reduced blood glucose on a daily basis on the low carbohydrate diet. This is a more detailed view of that continuous glucose monitoring. Again, you can see the separation between the blood glucose, with the lower levels being when the athletes were on the low carbohydrate diet. The graph on the bottom actually shows the data from 3 individuals who, when they were on the high carbohydrate diet, turned out to have pre-diabetic blood glucose levels. This was unexpected. None of the athletes had any signs that they were actually pre-diabetic prior to entering the study. But this continuous glucose monitoring revealed that 3 of the individuals were pre-diabetic, but their pre-diabetes completely resolved when they were on the low carbohydrate diet. So this is important information to know about what a low carbohydrate diet can do. So the conclusions by the authors, as well as my conclusions, are one, that once a fat adapted to a low carbohydrate diet for 4 weeks, these athletes had equivalent performances as they did on a high carbohydrate diet. Thus, dietary carbohydrate intake does not improve athletic performance. Number 2, subjects achieved amongst the highest rates of fat oxidation yet measured during the latter stages of the 6x100 meter running interval session when eating the low carbohydrate, high fat diet. 3 of the 10 athletes had blood glucose elevations in the pre-diabetic range when consuming the high carbohydrate diet, which then normalized on the low carbohydrate diet after 4 weeks. 4, all athletes experienced lower blood glucose with a reduction in the mean blood glucose of 17 milligrams per deciliter and lower glycemic variability, with the coefficient of variation decreasing by 4 milligrams per deciliter on the low carbohydrate, high fat diet compared to the high carbohydrate diet. 5, even competitive distance runners are not protected from the metabolic effects of a high carbohydrate diet. You can see these athletes who were regularly running multiple miles a week could not avoid becoming pre-diabetic because of the diet they were consuming. Number 6, those with type 1 diabetes who enjoy exercise, even intense levels of exercise, no longer need to feel that a low carbohydrate, high fat lifestyle will compromise their sports performance. So exercise presents some special challenges for those with type 1 diabetes. Exercise can increase, decrease, or not affect blood glucose levels, and which of these actually occurs with any given exercise is difficult to predict in advance. In those without diabetes, aerobic exercise typically increases muscle glucose uptake, and the decrease in blood glucose reduces beta cell insulin secretion that increases both gluconeogenesis and glycogenolysis. But in type 1 diabetes, hypoglycemia during and after exercise can result from continued absorption of injected insulin while the muscles continue to take up glucose. A low carbohydrate ketogenic lifestyle causes the muscles to utilize more fat and less glucose for energy. Less muscle glucose uptake during exercise reduces the likelihood of hypoglycemia during and after aerobic exercise. By contrast, intense aerobic resistance or high-intensity interval training exercises can increase epinephrine, cortisol, and glucagon secretion, all of which increase gluconeogenesis and glycogenolysis, resulting in hyperglycemia. This occurs in those with and without type 1 diabetes in order to supply glucose and fat to exercising muscle. In those without diabetes, The post-exercise hyperglycemia is quickly corrected by beta cell insulin secretion. However, in those with type 1 diabetes, post-exercise insulin administration will need to be administered to correct hyperglycemia. Because muscle glucose uptake can continue for hours after exercise, caution must be used when determining the bolus insulin dose used to correct post-exercise hyperglycemia. Since post-exercise hyperglycemia is a normal response to exercise, those with type 1 diabetes should not avoid exercise in order to prevent post-exercise hyperglycemia. Rather, they should carefully dose bolus insulin to correct it. Personally, I include that correction dose on the next meal that follows the exercise. That way I don't have to take 2 injections, which might tend to cause insulin stacking and therefore hypoglycemia. Exercise-induced hypoglycemia can occur during exercise with type 1 diabetes. This exercise-induced hypoglycemia results from 2 factors: increased blood flow at the insulin injection site that increases the rate of insulin entry into the bloodstream, and improved insulin sensitivity due to an increase in insulin-independent muscle glucose uptake via AMPK. AMPK, which stands for AMP-activated protein kinase, is a cellular enzyme that acts as an energy level sensor within a cell. AMPK increases energy generating processes like glucose uptake and fatty acid oxidation, while decreasing energy consuming processes like protein and lipid synthesis, contributing to improved metabolic function and exercise capacity. AMPK essentially acts as a master regulator of metabolism in the body. Other factors involved in exercise-induced hypoglycemia include excess exogenous insulin on board, as well as hypoglycemia unawareness, which is a condition that occurs in a fair number of persons with type 1 diabetes, in which they experience a reduced blood glucose threshold of less than 55 milligrams per deciliter or less than 3 millimoles per liter before hypoglycemic symptoms occur. Practical solutions to prevent glucose excursions with exercise. Firstly, planning exercise in advance can help reduce glucose excursions with exercise. For example, taking a walk or run at the same time each day will allow for the preceding meal insulin bolus to be adjusted to compensate for the activity. If the time, distance, and pace of the walk or run, for example, is only changed gradually over time, the bolus insulin dose can be gradually adjusted to compensate. This strategy also works for resistance exercise and may work for high-intensity exercise as well. However, some find that hyperglycemia after planned high-intensity exercise may not be preventable, since a pre-exercise bolus insulin dose could result in hypoglycemia at some point during or after the exercise. That is to say, the glucose response to high-intensity exercise is variable. Trial and error experimentation is needed to determine the best strategy for each person. Blood glucose changes with unplanned exercise can be addressed with glucose tablets before, during, or after exercise to prevent or correct hypoglycemia, or with a post-exercise bolus insulin dose to correct hyperglycemia. This concludes my talk for today. If you want more information on the use of a low carbohydrate lifestyle for type 1 diabetes, I recommend my book, Master Type 1 Diabetes, the simple, low-cost method to normalize blood sugars. You can also visit my website at www.ketogenicdiabeticathlete.wordpress.com. And if you have questions, feel free to email me at krunionmd@gmail.com. And my book is available on Amazon in 3 different formats: Kindle, paperback, and hardcover. I thank you for your attention, and I hope this talk was helpful to you. Thank you.